Good afternoon. Welcome to another one of our COVID-themed medicine grand rounds. I'm Bob Wachter, chair of the Department of Medicine. I keep thinking that we will reach a point in the pandemic where we no longer need to have these, but everything continues to be interesting and complicated, and I think there are probably as many questions that people have now as they've had at any time. So we'll keep going as long as that is the case. The ground rules are up here, Zoom window in full screen. If you have questions, type in the Q&A box. I'll have most of the questions, but if you have a few, I will try to get to some of them from the audience. Closed captioning is available at the bottom of the screen, and as usual, we will post this on YouTube tonight at probably about 6 or 7 p.m. and prior sessions in this series have been viewed about 2 million times. Today, I decided to go with 3 of our favorite experts and really just do a round robin potpourri of questions. And I'm sure we'll all get into it because not everybody agrees on everything. It seems like a lot of questions are coming up, I think particularly around the new CDC guidelines, but we'll go to that, a lot of other places, including the schools, variants, et cetera, et cetera. So the 3 speakers, if you've been following this, you know them all now quite well. Peter Chin Hong is professor of medicine in our ID division. He's also associate dean for regional campuses at the UCSF School of Medicine. He also directs the immunocompromised host infectious disease program at UCSF, and he does not wear that sombrero everywhere. That is just when he's doing videos. Peter, welcome. Our next guest will be Monica Gandhi. Monica is professor of medicine and associate division chief of the Division of HIV Infectious Disease and Global Medicine. She also directs the UCSF-Gladstone Center for AIDS Research and is the medical director of the HIV clinic at Ward 86. And over the pandemic, Monica has become quite well known nationally and internationally for her really thoughtful approach to where we are, and I think particularly her kind of optimistic approach, which we will dissect in the next hour. And finally, George Rutherford is professor in our Department of Epidemiology and Biostatistics. He serves as medical director of prevention and public health for the department, and for all of us, he has been our go-to expert on all things epidemiology, and I can't imagine how many talks George has given this year, but we're grateful to him for educating us and appreciate him coming on Grand Rounds for what must be about the 20th or so time. I don't know if you're keeping count, George, but it's been a lot. Thank you. So I'm going to throw out questions to everybody and just chime in, and I'm sure there'll be a lot of back and forth. Let's start with the obvious start. Did the CDC get it right or wrong last week in their new guidelines, particularly about indoor masking? Who wants to start with that? Go ahead, Monica.
You know, they were perfectly right and sound in their science. What ended up happening is that there were 2 ways to think about what went wrong. One is that one way we could have approached it is to say, let's wait until there's a certain case metric and a vaccination rate in the municipality, and then lift mask mandates for everybody. So I had been advocating for let's wait until everyone over 16 could get their second dose, confirm, do that cross-check with case rates, and lift for everyone. The second, but what they did in their guidance, which was to say that vaccinated people have very high effectiveness in the real world effectiveness trials. And they actually, listed 3 of them, including the Qatar study against the variants. Luckily, the variant story is calming down. 97.4% effective against the variants B1351 and B117. They referenced their own study from March 29th, the CDC MMWR, 90% effective even with asymptomatic infection. And they referenced the Israeli healthcare study in May 6th in JAMA, 97% effective, really effective vaccines. They also really, in the press conference, listed only 2 out of 11 studies that show a massive reduction in asymptomatic infection, which would be your ability to transmit if you felt well. They listed the Israeli study from May 6 in JAMA and their own study, but there's actually been now 12 studies, I should say 12, that show about 92 to even 100% reduction in you getting it in your nose to be able to pass it on to someone else. So all the science is sound. This is something about messaging, right? And one other thing I want to say is that if the CDC and Dr. Fauci and even the president had been messaging to the nation that our hospitalizations had already come down massively, severe disease had come down massively. Cases since April 14th had been plummeting. April 14th was the day we got 40% first dose vaccination rate in the country. If we'd been messaging in California that we have right now a 0.03% test positivity rate in San Francisco, 0.8% test positivity rate in California, then when this messaging came out, we would have all been saying, hey, things are going great. This totally makes sense. Instead, we messaged, we're not fully vaccinated. This is still worrisome. Stay at home, wear a mask, save lives. And then all of a sudden, the good news came out. And it was really shocking.
Yeah. So you see this as sound science and a problem with communication and getting people ready for it. And it sprung it on everybody. I've spoken to senior leaders in the state, in the city, and actually in the White House who said they did not know it was coming until the day it came out. So mostly a communication problem rather
communication, but not just communication that we could have lifted them all for everyone, but the communication that we were not messaging good news. Getting back to your statement that I'm too optimistic. We had not been messaging that cases were coming down, that the virus was already so much less in terms of severe disease. Anyone who was going in the hospital were yet to be vaccinated. And we had not been messaging that. The messages were, it's still scary, stay at home, things aren't going well. And then all of a sudden, it was not preparing the public for the good.
To get ready for it and too abrupt. It certainly didn't prepare the people who own stores and schools and workplaces. Everybody is starting to scramble. Peter, George, you agree, disagree?
Yeah, so I can weigh in, and we'll have Jorge give his 2 cents at the end. I mean, I agree with Monica that the science is sound. I would say as a caveat that the studies in Israel, et cetera, were at higher countrywide vaccination rates at the time when they were done compared to us. But, and to Monica's point, it would have been great if we could have more discriminatory reopening with reaching a threshold at a certain point in a particular region. Because, we're probably not going to be there uniformly as a country to that magical number, but certain regions like the Bay Area, et cetera, are already close to that marin, together with vaccination rates and case count per 100,000 could be kind of a nice metric. But I agree completely about the communication. It reminded me of the communication when we went from ICU beds as a metric to all of a sudden everyone was in purple. And I remember everyone sort of like being shocked that Governor Newsom changed that, metric to the 4-tiered system at that time, and no one knew what to do, and people were worried. So I think some preparation beforehand could have been great, and that's probably why California is waiting a little bit. They wanted people to have a little bit more time to sink in. I would say, like in the medical community, when I talked to people, everyone was kind of shocked about that announcement and didn't know what to do, particularly with the indoor setting.
Yeah.
Peter, I just do want to add, those studies weren't just done in Israel with higher vaccination rates. As you know, the March 29th study was done in our setting with high community transmission across frontline health care workers, frontline responders, the hospitalization data of over 65-year-olds that they cited from the CDC was done still with high community transmission and still extremely high effectiveness of the vaccine. So I really want to push back on that comment, just because the United States, they referenced the United States CDC data in their press conference.
But a countrywide, just one point here, just a countrywide of Israel is not necessarily the same as a healthcare worker population or a senior population.
That's why they referenced the countrywide of the US in 2 of their studies, including the over 65-year-olds in the CDC MMWR publication from just 4 weeks ago. So across the entire country, the United States.
Let me break in for George. And George, specifically, I have not heard Peter or Monica say a word about, all right, the guidelines make sense scientifically. I read them and they make perfect sense if everybody who is unvaccinated wears a mask. And yet we're sure that they won't, or at least some of them won't. There's no way to tell who's vaccinated and not vaccinated. So given the real world context, which is, this is not some controlled trial that you can control everything. People are going to do what they do, and you don't know that someone's been vaccinated if they take their mask off. Can you address that as you sort of comment on whether you think the new guidelines are reasonable?
Well, therein lies the rub, of course, right? And that's why California has pushed it for another, basically a month to try and get all this stuff straight. The other thing is that, the state doesn't want business owners to be the enforcers of masking and vaccination. And they're trying to figure out what to do. Now, of course, they've already dug their, there's been one hole dug where the federal administration and the state administration says, we're not going to be behind. We're not going to get with vaccine passports. So it's, that's one pretty straightforward solution. And they've already said no to that.
So let me just be clear. So one thing that could have happened would have been the feds or the state say, we're going to create a vaccine authentication system and digital and reliable, and it's not going to be theater, it's going to be real. And we'll set it up so that maybe we're not going to be enforcing it at the Starbucks, but if a business is going to parse people into vaccinated or not vaccinated, there's going to be a method to do that. They could have done that. They chose not to do that.
It chose, and New York did choose to do that. They have an app called Excelsior.
Yeah.
So, that's it. Now we're going to wait for a private sector solution, and there'll be 600 of them, and they'll be all over the place. So, that's a bit of a flail. But if you have to think, if you're the director of CDC, you're looking at half the states have gotten rid of mask mandates, or almost half, and half haven't. And so you're right in the middle, and I can understand why they want to do this. The messaging was very problematic, as Monica and Peter both pointed out. But it's not the wrong move. I think California is also not the wrong move. And in fact, I think it's the right move to try and take a little extra time to get this straight and to figure out exactly how this is going to be implemented on the ground.
So just so we're clear, if California got it right and the delay of a month is a good idea, is it solely just to give people more time to sort out authentication and all that?
Get more people.
Or is it that the case rates are going to be so low and the vaccination rates are going to be so high that if somebody's next to me at the Starbucks or at Target and is unvaccinated and is unmasked, it's still super safe?
Yeah. If you're vaccinated, it's super safe, right? If you're unvaccinated, it may or may not be.
All right, go ahead, Mike. Let's let George finish, and then we'll go back to you. Okay.
No, that's okay. It's just that I think the other thing to remember is that in this month we're going to get another 8 million doses dispensed at 200,000 a day, right? In the next 40 days. But
the question is
a long way down.
What magical happens in a month? In a month, have we sorted out?
Lots more people are vaccinated.
There's more people vaccinated, so that if that person who's unvaccinated does not have a mask, it's highly unlikely that they're going to have COVID in their nose. Is that why a month is valuable, or is it?
Yeah, because there's that much less transmission.
So it's
even if they're completely susceptible, they're much less likely to come into contact with the virus.
Okay. All right, Monica, go for it.
I think my concern about what we just said is we were actually already there. So, and again, it's that kind of idea that we didn't message. If Governor Newsom had been messaging how well the state was doing, it wouldn't have seemed like a surprise and businesses wouldn't have felt frightened. So for example, we're at a 0.3 test positivity rate in the city of San Francisco. The state is at a 0.9 test positivity rate. If you look at the number of cases over 100,000, the UK has used a metric at about 2 to 3 cases over 100,000 to have full in-person learning for schools. When they reach that 2 to 3 over 100,000, all restrictions in schools, for example, were off.
So let me just be clear. When you say 2 to 3, it's 2 to 3, an average of 2 to 3 per day per 100,000 people. So San Francisco today is averaging about 20 new cases a day in a city of 900,000 people, which translates to about 2 cases per 100,000 people per day. And that's the threshold that you think is so low that it's okay to, the CDC guidelines would have been appropriate in San Francisco.
Exactly. For example, the way that UK put it is 21 over 7 days. So it actually ends up being an average of 3 over 100,000. And we have been below that in San Francisco for a while. Like you said, 18 cases in the city yesterday, and we did 4,060 tests. So we sure test a lot, but we still have those low cases. And the same thing with the state. And so if we had messaged how well we were doing and then said we're going to follow the CDC guidance, it wouldn't have been a surprise because we are at that point. And so when we say that we're standing next to that, all these unvaccinated people are going to come in and put other unvaccinated people at risk in a store, they're not, because again, the community transmission is so low. We can't ever talk about vaccination status again without putting in our community transmission rates into that equation. Yeah. And California was there. So you are protected by both your vaccination, and an unvaccinated is protected by low community rates. That's how my 11-year-old is protected.
And you say that rate is so low, right, that even if I'm unvaccinated or I'm immunosuppressed and I got vaccinated, but it maybe didn't take, and I'm standing next to someone in line and they're unvaccinated and they're not wearing a mask, I should still feel fine.
Exactly. And so every time media calls me and they're like, would you feel safe doing that or that? I keep on saying, or would you let your 11-year-old be safe who's not vaccinated do this or that? I say, tell me the community rate, please, in that area, in New York or Dallas or Chicago, wherever you're calling from.
And
then we'll put those answers together.
San Francisco is at that rate now.
San Francisco's been at that rate for a bit, and California is also at that rate. Okay. So because of our high vaccination rates.
Got it. Peter, you wanted to weigh in.
Yeah, so I would say in response to Monica, I completely agree. But the point is the messaging didn't occur. So I think that's why I would agree with Jorge that we needed to take a delay, put on the pause, because, for 3 reasons, really. People needed time to adjust. People are still
the good news. They needed time to adjust to the good news.
The second reason is, like Jorge was saying, businesses didn't want to be the vaccine police. So they had to be a way to figure that out for the state to give guidance. And the third reason is, as was mentioned, hopefully more people will be immunized to make it even a safer place to be in.
Right. But so let's say a month passes, the vaccination rate continues to tick up, the case rate continues to tick down, and California says, okay, it's time to do something. Is that something now that unvaccinated people no longer need to wear masks, that the rate is so low that it's time to take the mask off everybody? Or is it still what the CDC is saying, which is unvaccinated people should wear a mask? George, it looks like you want to weigh in.
So to start, the other sort of factor in all of this that we haven't really touched on is that the state doesn't want to be doing this county by county anymore.
Okay.
And so I can tell you in Lassen County, as of this morning, 21% of the population was vaccinated. And in Marin, it was 60%. So there's big differences county by county. I think that there's another point here, which is where they say everybody get rid of the masks. And I think that's a point that'll come later. I think what we're saying now, what the CDC guidelines say, is that if you're vaccinated, you don't need to wear a mask, period. Which raises the question, how are you going to figure out if somebody's vaccinated or not vaccinated? Are you going to put a V with lipstick on their forehead or whatever, And that's where the vaccine passports become handy. There's a future date, probably end of the summer, early fall, something like that, when the immunity rates are really high, and we continue to vaccinate at this rate, and we get all the adolescents vaccinated. We'll just say, okay, it's done. We're done. We're over. Done. Nobody needs to wear a mask. We don't need to do any of this other stuff. We're done.
All right. So, Monica, I'm a fully vaccinated person, as I assume all of us are. I say to people that if I go into the store and someone who is unvaccinated is not wearing a mask, I still don't want to catch COVID. And I know I'm not going to get super sick. I know I'm not going to go to the hospital. I know I'm not going to die. I don't know, unless you tell me I do, that the chances that I could have a breakthrough infection are so low, and the chances if I have a breakthrough infection that I'll get long COVID or something that's going to fog my brain even more than it currently is zero. Unless anybody can prove that to me, I still don't want to be standing next to an unvaccinated person who might have COVID. I understand the community rate in San Francisco is so low that the odds are, very small that they have it. But even as a vaccinated person, I'm still a tiny bit anxious. Maybe it's just my residual anxiety from the past 15 months, and it's not rational. But I think a lot of people are thinking that way, even if they're vaccinated. So what do you say to the vaccinated person in that circumstance?
Yes, I would say that we are coming off a really traumatic period, and anyone's, I don't think what you said is rational, actually, but I think that
this will not be the first time you probably
but I really want to be clear. We have to have compassion for each other. And in the same way that I, as a mask researcher, because I've written 7 papers on masks, some of them with George, a couple of them with George, I would never have said—
Pulitzer Prize. Go ahead.
I would never have said, wear a stupid mask to someone or ask someone to pull up their mask, because I don't, as an HIV doctor, I really believe in harm reduction and compassionate means of messaging. So I would never have said, you must wear a mask. I would maybe move away, but I would never have said that in a public space and as a public health messenger. In the same way, if vaccinated people want to continue to wear their masks, they should feel free to continue to wear their masks. And that is also compassionate. None of us should be yelling at each other about what we personally decide with masks. But what I'd like to reassure you of is that, break down each of your concerns, that so the CDC keeps track of breakthrough infections. And first they were keeping track of all of them. Then asymptomatic fell away. And then they were keeping track of symptomatic, and now severe disease is what they keep track of. There is essentially 1 in a million people who got sick from COVID after they had the vaccine out of 115 million Americans vaccinated. And that is across regions in the United States, including places with much higher community incidence than you sitting in San Francisco. 18 people were diagnosed yesterday with COVID-19 in their nose in a city that we all are sitting in, 896,000, 4,060 tests done. I think it's very unlikely that I will be running across those 18. And beyond that, I think it's very unlikely that me as a vaccinated person will be able to imbibe them as they're sitting next to me, hopefully wearing their mask, but even if they don't. Okay. And then finally, and I think I really want to stress this, I think the long COVID studies have really shown that, and especially the ones from UCSF, which are really well done studies, that it's symptomatic or severe disease that give you a disorganized innate inflammatory response that can give you symptoms that last a while. Having mild or asymptomatic infection in well-done studies with objective parameters, and I actually reviewed the post-acute sequelae applications for the NIH, don't happen after mild or asymptomatic infection. And your chance of mild or asymptomatic infection as a vaccinated person with 18 people in the city, again, is very low. So let's all try to put in our hats about community transmission, how things are going in their city or wherever you're walking around as you feel this anxiety. And it's also okay to feel anxiety. And trauma is real, and mental health effects of the pandemic are real. My only concern is I don't want that trauma to linger over and a signal of abnormal linger over into fall, because I want children back in school.
I appreciate that. Peter, anything you want to add to that or disagree?
The only other point, I agree with Monica about the low risk in general, and also the other point about not shaming people for wearing masks if they feel comfortable with wearing masks. There are lots of other reasons to wear masks for us, so we just seem to be monolithic and think people only wearing masks for COVID. But I hope that a legacy of all of this would be that we can wear masks anytime we have symptoms or a cold or, it's influenza season. But enough said. The one other point I would make about breakthrough infections is that, the estimates of 1 in a million are probably a little bit less than what the reality is, just given the fact that we're not swabbing everyone who's gotten a vaccine. But nevertheless, it's very, very low.
Okay, let's transition to the kids for a sec. So now we're vaccinating 12 to 15s. We're not going to be vaccinating kids younger than that for a while. I think Fauci said he thought end of the year yesterday. So what are the implications of that for young kids, for being in a crowd with vaccinated parents and unvaccinated kids? And should the parents be role modeling the mask if the kids need to still wear it? What are the implications for the schools? George, I think you took a grandchild to Disneyland this week. So why don't you tell us about that? And it sounds like the greatest risk to you was the number of steps that you had to do, but go ahead.
Yeah, Monica didn't hear this, but 32,000 steps with a 3.5-year-old because all the transportation systems were shut down. But it felt that was extreme.
Good exercise.
Extreme. It's a Disneyland was doing temperature checks and everybody had masks on who was over the age of 2. Under 2 and under, it's a strangulation risk, a suffocation risk, so you don't mess around with them. But yeah, I felt totally safe. It felt totally safe. Now, I think that, with the
So George, you
implication.
had to keep your mask on even though you were outside and you're vaccinated the entire time. Nobody checked vaccine.
They didn't care about the vaccines. It's Orange County. They don't care about vaccines there.
Okay.
It felt totally safe and it felt under control. And there was a lot of social distancing built in.
Yeah.
And it was at 20% capacity too, Bob. So that was the best part of all.
Yeah, right. No line.
Yeah, exactly. I think in schools, so I would imagine, the school politics are incredibly complex and difficult, and school vaccination laws are incredibly complex and difficult. I'd like to think that we'd have most of the high school and middle school students vaccinated by the time school starts. I think elementary school children are going to have to wear masks and probably have some forms of non-pharmaceutical interventions like social distancing for a while until the vaccines come in. But make no mistake that the mortality from this disease, the number of cases of this disease, is right in line with all the other diseases we vaccinate for. So if you look at the number of cases of Haemophilus influenzae type B, they're at, or mumps or rubella, we're sort of right in that sort of range of cases. And I know the American Academy of Pediatrics is probably going to come down on the side of wanting these kids to get vaccinated just for their own health, period.
Mm-hmm. So Monica, George, so what do you think schools will look like in September?
I suspect that, I think probably the older kids, I don't know. I just don't know about the older kids because hopefully they'll all be vaccinated and they'll be done.
Hopefully, or you think there'll be likely requirements?
I don't think there'll be requirements. I don't think it'll be together in that period of time, but there may eventually be requirements.
Okay.
But if there really are vaccinated, then we'll be done and done. They may need to be vaccinated for things like the choir or the football team or something like that. Mm-hmm. Things like that. They may be able to enforce it for extracurricular activities, but it remains to be seen. I think elementary schools, the kids will be wearing masks.
Okay. Monica, you were shaking your head.
Yes, I think a paper that a commentary I wrote yesterday got some news coverage, but maybe not enough. But this was too well. I wrote it with Dr. Amy Beck, who's on faculty at UCSF, who in the pediatrics department. And this was two really well done studies in hospital pediatrics that were published yesterday. And they showed that actually this question of severe disease in children, we really do know the epidemiology in the sense that children are much, much less risk for severe disease. But the important thing about what this paper did is look at hospitalizations from September and February among children with COVID and did careful retrospective chart review and adjudicated that 40% of those hospitalizations were not for COVID. We do incidental screening in a hospital. Of course, everyone had COVID in their nose and they'd come in with a broken leg or something else completely, but had incidental screening in their nose and were not there for COVID. So that really gave us security that hospitalization, and we wrote a commentary on it and hope that that will reassure parents even more with these really well done studies. These were colleagues in California that did these studies, one from Stanford. So the reason I think that papers and that commentary that we wrote, I hope gets more attention is severe disease is very uncommon in children. Narratives can be manipulated, and that manipulation has led in a way to this fear of that's led to school closures. I don't actually think it's political. I think it's truly fear that we messaged in a way that there was something scary about being in school. Emily Oster has a paper that just came out today from Brown about it's actually safer than being in school than it is outside in the community because there were so many safety procedures. So I'm really hopeful that we can change this narrative. Mm-hmm. So the CDC recommends for children, measles, mumps, rubella, diphtheria, and pertussis as mandated vaccines because they cause more severe disease in children. COVID-19 does not cause more severe disease in children. So it will be an ethical question of whether type of schools can mandate those vaccines for young children. They can still, I actually had my 13-year-old vaccinated, not because I think he's remotely at risk for severe disease, but I'm all for helping the herd. Mm-hmm. And I want to help with some 50-year-old in Ohio that didn't get vaccinated. But that was the reason I did it. And in terms of masking in schools, what the UK did, and I would urge the United States to do the same, and I've been in touch with my CDC colleagues, and I think they're going to recommend this, is when cases are low in the community, about those parameters that we said, like 2 over 100,000, there will be no masking required in schools, because you as a parent can choose to mask your child, but it's the same reason that you, Bob, are masking now. There's more anxiety, but with the low cases, again, it isn't, there won't be transmission in schools. And do we think it's important for children to be unmasked in schools? Some people think it's important for development, and it's important for vowel expression and important for learning. So the CDC will be coming with guidelines.
So you might have a guideline that says schools absolutely have to be open, should be open, the teachers should be vaccinated, and all the adults, and the kids, whether they're wearing masks, really hinges on the community prevalence rate. If it's below a certain number, no. If it's above a certain number, you'd support it being yes?
Correct. And that's exactly what happened in the UK. They opened schools successfully once they got to that metric. No masks, no distancing, and they've had no increased community transmission upon opening their schools. So I think that the US will likely follow the UK example.
Right. Peter, you want to weigh in?
I would just say by the time that debate is settled, the kids would all have been vaccinated anyway, and that ultimately will reassure most folks, data or not, in the other camp. And that's where I feel like it will end up running.
I thought you were going to say by the time that debate is settled, the kids will have graduated college.
Yeah, no, but I agree with. I mean, all of us at UCSF have been so passionate about having the schools remain open during the pandemic, despite all of the fear that people had, and I think that is actually one of the biggest tragedies that happened in our state during COVID.
Peter, there are a lot of questions on immunocompromised patients. We talked about it here on Grand Rounds 2 weeks ago, but why don't you give us your take? Immunocompromised patient got vaccinated. Should they be tested? How do they manage their lives now when there's some uncertainty about the level of immunity that they have?
Yeah, so Bob, not much has changed since the last time we spoke in Grand Rounds. You presented this in Grand Rounds. And to summarize, we have studies showing that levels of spike protein antibodies 2 weeks after full vaccination amongst transplant and some immunocompromised patients around 50%. The second point is we don't know what protection means necessarily, simply because that spike protein antibody is only picking up one part of the immune arm. Although, when you talk to immunologists and we invoke, maybe we can do a T cell, assay, and I'm sure Monica will have something to say about this, but that if you are low in spike protein antibodies, you're likely also going to be low in that T cell adaptive assay. So, you may not get much more bang for the buck by adding that test in, although it would be kind of interesting. I know it's being studied. So that's the second point. The third point is that, this is a very special population. So when we look to say, hey, look at data, there are only 7 people hospitalized in that study in Florida who had gotten full vaccinations because of transplant. That may not be a generalizable population, because transplant patients are in general very, very risk averse. So they don't act in the same way to say that, well, I'm not having as many breakthrough infections because I've got full protection in this population. Therefore, even if I'm not detecting antibodies, there must be some, other immune parameter that I'm not detecting that's responsible for them to be protected. So that's the only caveat I'm about to invoke. At the end of the day, I think we still feel uncertain. In the beginning, we said don't check antibody tests, but I think a lot of providers are doing that, mainly because if you're positive, you can at least feel a little bit more reassured. If you're negative, then we would give that same universal message. We're not really sure right now. There are strategies that we can talk about that people are trying to do, but for now, you just protect yourself as much as possible.
And if you're positive, Peter, do you consider yourself vaccinated in terms of the rules about going into the Starbucks and taking the mask off and having a dinner party and all that?
If you're positive as a transplant patient, if you have a positive
and you have antibodies, yeah.
Yes, the caveat is we don't know how long it will last.
Right.
But yes, I mean, at this point, given the low community prevalence, again, that's the second dimension of all this.
Right.
I feel fine.
I think the other thing. Sorry, excuse me.
No, go ahead. Yeah.
I think the other thing to add, and I think you brought this out a couple of weeks ago, Peter, is that you should build an immune wall around these patients,
Yes, yeah.
get everybody in the family vaccinated, and not mess around with it.
Yeah. So I think the best thing the immunocompromised patient can do, thank you, George, is vaccinate everyone around them. So if they have like a buddy that they go golfing with and that buddy is a little vaccine hesitant, then maybe find a new buddy or try to convince that buddy to get a vaccine. I love that idea. That actually is the most proactive thing an immunocompromised patient can do.
Okay. Let's talk about the vaccine uptake rates. And obviously the Bay Area is doing very well. California is doing well. Other states not doing well. We've learned that this doesn't parse quite as much on race and socioeconomic status as we thought, and parses maybe more on political affiliation and what team you're on. Strategies to increase that, or we're learning that for some people this is futile and they're just not going to get vaccinated. People now we talked already a little bit about the passports, but do you need to require it for the workplace? Should we be giving incentives or penalties for people that don't? What do we do to get that rate up? Monica, you want to start with that?
Yes. I do want to just add one thing. The T cell assays that you send commercially are really different from what we can get in research labs. And so we did an analysis that we just published in Lancet HIV where antibodies were down in people with HIV after vaccination, but the T cells that we could run in a research lab were just as robust. So I am hopeful that the redundancy and complexity of the immune system will help us out with immunocompromised patients. And we did put a grant in to ask questions about that.
Right.
In terms of the vaccination strategies to help with the hesitance, I actually thought the New York Times had this really great article. I hated their headline because they said, these are the people who are holding you back, which again is not compassionate messaging. And I think we as physicians, again, there is this different way that public health talks and physicians talk about a compassionate way. So they broke it down into 4 groups. And one is, like you said, less about the medical mistrust in racial and ethnic diverse communities that have traditionally accompanied this with community-based messaging. There is a way to really work with those communities. And we did a campaign on Saturday in the Bayview around this, where we were just actually sitting there, didn't say a thing, and really community was messaging to community in the Bayview. But the other things that came out were really, I thought, fixable, some of them. One was access. So it turns out that if you are working, you can't take 2 hours off to go get the vaccine because they will not give you those 2 hours off free. And so it really is about bringing vaccines to the workplace, or of course the employee please giving them time off and giving them paid time off to go get it. So a lot was about access. I'll get it when I get it. The third was around this idea they want to wait a little longer. Some people want to wait a little longer, make sure that it's still safe and that enough people have been vaccinated. That's a perfectly valid reason. And it will happen hopefully soon as we make things more accessible with President Biden's plan to put in rural communities. And then in terms of Republicans, the concept of Republicans not wanting to get vaccinated or concept around party lines, there's 2 things to think about. These were developed under the Trump administration. They've been rolled out in the Biden administration, and we sure have a lot of political divides. But I do believe one reason the CDC did this, and actually Dr. Fauci said this in a Medscape interview yesterday, is they said, we were watching focus groups in the Washington Post. There was a New York Times article that if you tell people that their masks will go away when they get vaccinated, they say they will. There was an 18% increase in Republicans saying they will go and get vaccinated the minute you tell me that masks can come off when you get vaccinated. So we are sitting in a city again where we may be preaching to converted, but I think it's really fair to say this was an impetus and a positive motivator. Dr. Fauci and the CDC thought to get people vaccinated. And we are on our final push to that 70% by July 4th that President Biden wants. And we may be sitting in a part of the country that we didn't realize how important positive motivation was. And then the final thing is there's going to be people who don't take it, and that's fine.
The CDC sort of was doing the math and saying, yes, there may be a few cases transmitted by unvaccinated people who aren't wearing masks. and some complexity, but we are also sending a message out that if you're vaccinated, you can get back to normal faster. And we believe, and we've modeled, I assume, that that will save more lives than a few new infections because of
focus groups. Yeah, they were doing a lot of focus groups, and they were actually published. And then the final reason is, if there is a really angry, you just can't get around that you think these vaccines aren't safe, that is also okay, because I love the herd. I love that enough of us can get vaccinated that we can protect those who are unvaccinated. That is herd immunity, and there will be people who won't get vaccinated. Again, compassion.
You are a very nice human being. Peter or George, want to add anything to that?
Yeah, I mean, Jorge, you can go. Okay, so my feeling is, my overall comment is, I agree with Gandhi about all those strategies and the various populations. I would just amplify one of the points, which is, it is really a travesty that some of the structural barriers people still have. There was a study in LA done recently showing that the proportion of Latino men who were vaccinated was just, I think, 39% versus other populations, 59%. And white men, for example, speaking to the fact that many of them are involved in these jobs, the same population that got COVID early on, but they can't take time off, even 2 hours, or they're afraid of getting a side effect, so that if they take time off the next day, then they'll lose their
income.
job. Mm-hmm. So I think overall, not one size fits all. My summary comment is, it's a bunch of carrots, there's a bunch of sticks. Carrots include things like, I don't think, the $100 thing, I'm not sure it will work necessarily. Some people actually get turned off by it, but people in states like are using, how much was it, Jorge, for that lottery?
$1 million.
Yeah. I mean, it's incredible, but I think
beer too, free beer and free donuts.
Yeah, Krispy Kreme donuts, and also So those are all in carrots thing, but maybe the soft carrot will look the best. Like, maybe you can't get into outside lands unless you're vaccinated, or the ticket is cheaper because you're in the vaccinated only section. And then the bunch of sticks include, school mandates, or college, entrance to college, going to this Bottle Rock and so on, or employees. I mean, there's a lot of talk now about Cal OSHA and requirements and employees and workplace safety. So that's kind of where I stand.
Yeah, George?
I was just going to recap what the financial incentives are. Serbia is paying 25 euros a head to get vaccinated, and that created a huge ethical issue, huge ethical dilemma. My favorite, Monica mentioned the get a shot, get a beer, some brewery in Buffalo. The governor of Ohio put up $5 million lottery tickets that people who can get a ticket for it when they get vaccinated. My favorite was a shot for a shot in New Jersey in bars.
That one was a good one, Jorge.
And so let's talk about herd immunity for a second. It's sort of the last several weeks, the Times said we're not going to reach it, and we should stop talking about it because it's not really a real thing. What's your current thinking about herd immunity? And I think I asked you this a few weeks ago, but I'd love you to restate it. Have we reached herd immunity in the Bay Area? And what does it mean to be talking about regional herd immunity? Is that even a thing?
Well, I talk about it all the time, so of course it's a real thing, Bob.
Of course, go ahead.
No, I mean, herd immunity is a real thing. We see it. Just look at the state prisons. We have several examples of reaching herd immunity in the state prison system. I think the way it'll work here is that it's going to be more regional, and the Bay Area will probably act as a region, maybe up from Monterey all the way up to Ukiah or something. That'll be a region. Coastal, urban Southern California will be a region, and then everybody else will be a region, or probably more than one. The vaccines are way far behind in the rural areas of the state, with the exception of a couple of counties like Alpine and Mono. But I think that the issues of who's going to get sick, who can take time off for work, those things are really amplified in the rural parts of the state. San Mateo County has actually done a really interesting thing. You talk about taking vaccines to the work site. They're taking it down to farms in Pescadero and vaccinating all the farm workers on site, which is the sort of stuff that's going to have to happen. It's going to have to happen to make this go. So herd immunity is a real thing. I think you may be seeing glimpses of it here in the Bay Area. I think you're seeing glimpses of it in Los Angeles and Orange County right now. Now, that's not because of vaccination. That's largely in Los Angeles, largely because of naturally acquired immunity or probably as much about naturally acquired immunity, but you're seeing these precipitous drop-offs in transmission. And I think what we're seeing is early, kind of the early signs of herd immunity.
Any idea yet how long natural infection induced immunity is going to last?
It's lasted till now.
And that's all we know.
That's what you know, right?
Monica, go. I know you have thoughts about that. Go ahead.
Yeah, I mean, I would say the one thing that I want us all to remember is we reached a 60% first dose rate in the United States yesterday. And I kind of was looking at two numbers as the biggest deal. 40%, it seemed, when you didn't have a lot of immunity in the population, like Michigan versus California, where we had a lot of natural immunity, like George said, because of our terrible surges. 40% seemed to be where cases plummet. That's why I want India to get more vaccine. And then 60, and that happened on April 14th in the United States. And then 60% is a huge hallmark first dose of when, even as you open, as Israel was opening, as UK was opening, kids back in school, all of that, no mask, no distancing, there still weren't increase in cases. And in fact, had 3,000 people in that Liverpool nightclub, maskless, sweaty on the floor, just as a check in Liverpool, and still no increased cases. That was on May 5th. Okay. So you can really open up, it looks like, with that 60% first dose rate. We reached that at least countrywide, but there's variability.
And the Bay Area, the Bay Area is over 70 now, right?
Yes, we're actually at 77% first dose. So yes, I think we have herd immunity.
Among eligibles.
Yes, but that's a very good point, that you have to divide it among adults and the total population. Right. So we reached 60% first dose in the United States among eligibles, which is the CDC is currently defining as over 18, because Moderna goes to 18. But the rate yesterday was 48% among the total.
We're about to hit 50% of the total U.S. population having one shot.
Right. So the reason this is important is we can model, again, all we have to do is look at places that went faster, and we can see they just, even when they're opening, they're not seeing these increased cases, which is why I think the CDC decision the other May 13th, again, not well communicated, but was wise. But in the state of California, remember what herd immunity means. It's not eradication. It means that we get enough of the population immune, either through natural infection or through vaccination, that the non-immune among us, those who are unvaccinated or those who are children, are protected from infection by everyone else's immunity and by low case rates. I do believe we're there in San Francisco by the traditional ID definition, and I think we're likely even there in California.
Okay.
Going to duration of immunity, I have an article coming out on Monday about this, which I hope I'm going to explain it really better than like you would do in a Twitter forum, but because I think you really need to put things down on paper and write it. But I think this is the really important point about the durability of immunity. Is remember, we have antibodies, we have T cells, but then we have memories, and our memory B cells, and our memory B cells and our memory T cells are the ones that last a really long time. So long that these people who got 1918 influenza, 90 years later, they had memory B cells, and they put in a test tube, they put the influenza 1918 strain, and they produced really strong neutralizing antibodies against that strain and protected from infection in mice 90 years later. So you want to develop memory B cells, you want to develop memory T cells to the vaccines. And we have that data now. There was a study that biopsied lymph nodes after people had gotten the mRNA vaccines. And at 3, 4, 6, 7 weeks, you could see memory B cells forming in the germinal centers after vaccination. Nadia Rohn here at UCSF just put up a preprint, an amazing paper on how memory T cells are formed after the vaccine you can see that it's differentiating into memory T cells. Those last a long time, those last a lifetime. So I actually am very hopeful that we're going to have long-lasting durable immunity after vaccination.
Let me agree with Monica. I mean, and just to point out the obvious, that if we had to keep neutralizing antibodies circulating for everything we've ever been exposed to, the blood wouldn't circulate too well.
It would be thick with antibodies.
One big antibody, right?
One big protein, protein blob.
So when I heard that the CEOs of Pfizer and Moderna say we're going to need boosters, I sort of discounted that a little bit because I imagine their bonuses are tied to their stock price. But now Fauci's saying it and others are saying it. Why are we going to need boosters if you think that we are in the next year? George?
Things change.
Things
change with more data. I think Dr. Fauci will. I think he said that yesterday. I know, but I think it will change.
Meaning you think we're not going to, or
we're going to not need boosters, and I think Dr. Fauci will message that as well.
Okay, George, what do you
All
think?
right, I will have won that bet then. Good. The boosters are about bumping up antibody levels. We boost to diphtheria, we boost to tetanus.
Yeah.
Right. This is about broadening the base, and it's about escape variants and some gnarly variant that's coming down the line that we've yet to see that we might have to create new vaccines to. I think that's a kind of a theoretical question right now. And as Monica points out so aptly, there are lots of places on the spike proteins where T cells can interact and
82 places. If you have 13 mutations,
82.
you'd have knocked out 82
number,
T cells.
Yeah. Go ahead,
it's like approximately between 81 and 83, as I recall.
Right. Okay. So the point is that neither of you are sure that we're going to need boosters. There's a possibility that some variant is going to come out of the woodwork and be somewhat resistant to the current vaccines. Is that where you're living right now?
That would be what would push it. Yeah.
Right.
It's why global vaccine equity is the most important thing we should be thinking about right now, because variants can't come if the virus isn't transmitting. And beyond that, and one final point I want to make is coronavirus is a DNA virus wannabe. What that means is it isn't actually a very rapidly mutating virus like HIV or influenza are. Those are RNA viruses with very polymerases that like to make mistakes, and they accept it. Coronavirus doesn't accept those mistakes. They have a very strong proofreading mechanism like DNA viruses do. So if we keep our transmission low, we're not going to see this thing mutating like this. So we need to keep transmission low. We need to get vaccines to where the world needs it.
Peter, what do you think about the booster question? Anything different?
So I agree that coronavirus, I always thought from the beginning, is not a hard virus to really mutate in a way that you would need new vaccines to really overcome the neutralizing antibodies you had already developed to the original vaccine. And I think whether or not you get a booster is really not going to be about waning of immunity as much as some weird variant that comes up because of uncontrolled, variant production, because of ongoing transmission in the rest of the world. So I agree with everything that people said, that, if it were for just an antibody response that we have from the original vaccine, that's probably going to last for years and probably won't need a booster. The only reason we would need one is for a new variant that's going to come. But again, our immune system is so redundant that I'll be surprised if people get enough high rates of vaccination to make that force field that we'll actually really need one in the winter time. So the answer is no.
I mean, obviously we've gone through the phase of, oh my God, South African variant, oh my God, Brazilian variant, oh my God, now Indian double mutation variant.
Or triple mutations.
Triple mutation.
It has 13 mutations. We can still fight it with our T cells.
Out of the 82 slots, the numbers get confusing here. So Peter, what are we learning about the variants that are either reassuring us or maybe should make us a little bit concerned for the future?
Well, I think there's several lessons from the variants. The first is that if you have an mRNA vaccine, it's actually, we weren't really putting the vaccines in a hierarchy, but if you have an mRNA vaccines, because it's making so many antibodies against much more of the spike protein, probably than some of the other types of vaccines, if you talk about vaccines around the world, it probably is enough to overcome many of these variants. But not all the vaccines are going to be equally efficacious against all the variants. And we've seen evidence of that, like AstraZeneca with a variant in South Africa, or many of the Chinese vaccines against some of the P1 variants in South America. So, for the ones that we have now in Operation Warp Speed, I feel confident about. I don't feel confident necessarily about all the vaccines around the world. And in fact, some people think you'd need a booster depending on if you get an inactivated vaccine from Sinovac or Sinopharm, for example, versus an mRNA vaccine.
So that's a question that's coming up. People who got vaccinated, they were in China and they got their vaccine there and they come back to the States. What are you going to tell them if they see you in clinic?
I think it's going to be tough. It depends on which vaccine they have. I think China has at least 5 approved vaccines right now. 2 of them are always in the headlines, Sinopharm and Sinovac, because it's being used as vaccine diplomacy to sort of which is also a good thing because the rest of the world doesn't have a lot of vaccines. So I'm all for people giving vaccines to the rest of the world. But if they, it's a tough thing. If there's enough vaccine in this country, and they have a vaccine that's not on the WHO approved list, and I'm not really confident about the data, and depending on variant circulating, I might ask them to get, another one here. Another possibility is to get an antibody test, but again, I'm not really sure what it may mean in this context.
All right. Either of you, George, you want to weigh in on that? And by the way, if you want to bring in a prop like Peter did, you're free to do that.
Oh, like that hat he has? You mean that one?
No, he had a little stuffy thing. Cool.
Okay. Oh, there you go.
Go ahead.
Yeah, I mean, the University of California system's facing this right now with a lot of students coming in from overseas. And what do you do with them? The Sinopharm and Sinovac are protein vaccines. Novavax is a protein vaccine, but it's not licensed here yet. And we talk about this as being in China, but these are extensively used in Latin America, including in Mexico. So this is something we got to really wrap our heads around here pretty quickly, and really develop an understanding of what we need to do with these patients as they present. Do they need to be reimmunized? Is it just leave well enough alone? The counterexample here is that there's ongoing transmission in Chile and the Seychelles Islands, hardly the two countries you'd use in the same sentence very often. And they both used a lot of Sinovac. So that's the concern, that even in when you get into situations with ongoing transmission, which hopefully we won't have, because Monica's completely right about community viral load, or however we put it. It's, the things just don't work that well, and at least so it would appear. And I think we're going to need to wrap our heads around whether we need to revaccinate people coming from these who've been primary vaccinations with these other less effective agents, and or not.
So the choice will be just hope that they got it and hope that the community rate is low enough that it's okay. Yeah. Check them for antibodies and revaccinate if they don't have antibodies, or
I'm not that big on checking it, but like I suppose you could do it. But
all right, Monica.
The one thing I want to add is that Covaxin, which is the part of the pharmaceutical product, is also an inactivated whole vaccine, a whole virion, just like Sinovac and Sinopharm, but it actually seems to work better than the Sinovac and Sinopharm. It had its latest press release on April 21st, did have 100% efficacy against severe disease and 78% against mild, which is why there are people who are getting reinfected if they have a lot of inoculum, like you said, George, that are being exposed, healthcare workers. But the AstraZeneca really does have those multiple points on the spike protein that T cells react against. And so I'm not as worried about AstraZeneca. I'm not as worried about Covaxin. I'm more worried about Sinovac and Sinopharm.
Okay. Corey, what about Sputnik 5? Do you like Sputnik 5?
I didn't like that some batches had replication competent adenovirus, but I also think that was like some batches. And what I really want is India getting vaccine, and Russia has now, there's a system in India, which I think is really unfair to people who don't have this, that you can go and get a Sputnik vaccine for 1,000 rupees at your local pharmacy, because Sputnik has made that available. I think the US, I would love for them to donate or loan more vaccines to India, because India needs whatever it needs.
George, give us the latest on India in the last maybe a minute or so left. What's the latest situation?
There's been a downturn in cases over the last week.
Yeah.
Who knows what that means?
I hope it's not just.
I was going to ask you.
Yeah, what that means.
You're supposed to tell us. What does that mean? Is that people being more careful?
It's better than going up, I guess. But I don't think it's anywhere near. I don't think it's about vaccine. It may be just that we may be saturating urban areas and there's underreporting in rural areas. I think that's probably the most charitable interpretation of it, and it hasn't gone down that much. It's gone down by about, what would you say, Monica, 10%, 15%?
Yeah, to like 280 instead of 360 last week. 1,000.
Yeah.
1,000 cases per day.
That's like the U.S. worst of U.S. at the height of January. Yeah.
So you think it? I mean, every surge we've had here eventually came down pre-vaccine. So they do come down at some point, mostly because of behavior and then some level of immunity from infection. You don't think that's, I think
it's a combination of, I think it's a combination of things. Plus there's underreporting and there's not enough reagents for testing and a whole bunch of other things, kind of like where we were maybe in the, like last spring. A year ago, last spring. And so it's a little hard to tell exactly what's going on, and it needs, we just need better data to really understand it. But there is saturation of vulnerable populations that are behaviorally the most vulnerable. There are changes in behavior. There have been lockdowns in many of the cities.
Yeah.
The interesting is air pollution has seemed to have gone away in New Delhi recently, or Delhi, and it's but then you have this complicated story of the variants that are maybe more transmissible, and the UK B117 variant is in northern India, but the double, which is really 13 mutations.
B1617.
Yeah, 617.
It's like that area code.
The Boston area, yeah.
is in Mumbai and Maharashtra. So it's a complicated story, and I think it's a little hard to interpret a line going up and down in the New York Times based on the data we have.
Yeah.
All right, we're tragic.
Yeah, it's extraordinary, and it makes it hard to feel as good as we should feel here. I think that's partly why it's hard to embrace full-on optimism, and we're getting back to normal when you see so much of this.
By the way, by the way, you look at the last week at WHO data, of the 5 countries with the highest numbers of cases are in South America in the past week. So Argentina and Colombia have made it onto the list.
No one is safe until this world is vaccinated.
That's right.
Well, that is a good way to end it. And thank you all for your thoughtful analysis and what you've been doing for the last 15 months, which is educating us lay people about the key issues in the pandemic, and doing it so thoughtfully. Really, really appreciate it. We'll probably have you back again in a month or two and see how we're faring. But at least the news in California and in San Francisco, it really is quite good. And I think we're all going to have to get used to feeling as good as you feel, Monica. I'm getting there. 0
hospitalizations at the general today, just as an important point. It's a big hallmark. 0 people in the hospital.
That's amazing. UCSF Health, I think 3 people in 700 bed hospital, whereas that number was 100, 150.
It's 2 days last week with 0 deaths in Los Angeles.
Yeah. No, it is amazing. The science is good. Vaccines work. People should take them. and all right, everybody stay well. Get vaccinated if you haven't yet. And we'll be back again in a couple of weeks for another COVID themed Grand Rounds. Next week, we'll have a regular Grand Rounds. And thanks again to our speakers and to our fantastic production team who are listed there. Stay well. We'll talk to you soon.